العلم يحلو كلما كررته ولذاك عدت مكررا لحلاوته.
هنبتدي أول محاضرة الأستاذ الدكتور علاء الدمرداش هيكلمنا عن Physiology of respiratory failure in newborn infant and basics of mechanical ventilation. الدكتور علاء خريج
المايك طالبين المايك،
ممكن اعلي صوتي شويه حاضر. الاستاذ الدكتور علاء خريج جامعه عين شمس هنا سنه 81، نيابه اطفال وزماله من نيويورك شنايدر تشيلدرن هوسبيتال. حاليا هو استشاري الاطفال والخدج في مستشفى الوصل في دبي.
السلام عليكم. صوتي كويس؟ أحب في البداية نشكر الدكتور محمد مصطفى والدكتور هشام والدكتورة رغدة. احنا مجموعة أطباء مصريين متخرجين من مصر، كان نعمل تغييرات كثيرة لما كنا في الجامعة، والحقيقة تقصير مننا فشلنا في الموضوع ده. فلما لقينا الشباب اللي موجود دلوقتي قدر يعمل التغييرات دي، قلنا احنا ممكن ننزل التحرير وممكن نحاول نفيد الشباب الدكاترة الصغيرين اللي في مصر بان احنا نقول لهم ايه الحاجات اللي احنا اتعلمناها، ونشوف ايه الحاجات اللي هم يحبوا يعرفوها مننا، ايه الحاجات اللي احنا ممكن نساعدهم فيها. فالجروب بتاعتنا دلوقتي اسمها Doctors for Egypt، والهدف بتاعنا ان احنا نقدم اللي نقدر عليه. مش مفيش حاجة معينة احنا عايزين نحققها، احنا عايزين نشوف الدكاترة المصر محتاجين ايه او يحبوا ايه، ونحاول نساعدهم يحققوا الموضوع ده. فالحقيقة مستشفى أحمد ماهر كانت قدوة في انها قالت احنا والله ممكن احنا نتعامل معاكم ونشارك في الخبرات ونتعلم احنا الاثنين من بعض ونستفيد من خبراتنا سوا مع بعض. فده بس احنا not for profit organization، احنا ما بنحاول نساعد، ما بناخدش اي عائد من الموضوع ده، واحنا الهدف منه ان احنا لو نقدر نقدم حاجة تحسن الخدمات الطبية اللي في مصر ده يبقى حاجة عظيمة جدا. فان شاء الله يبقى في تعاون اكتر. الناس اللي من مستشفيات تانية تحب تعمل نشاط معانا اهلا وسهلا، نبتدي الكلام الطبي شوية على أساس إن ده يخدم أطفال مصر وأطباء مصر. فهنتكلم في موضوع يعني طبعا هنا دكاترة الأطفال دي حاجة مهمة بالنسبة ليهم، إزاي يعملوا يعالجوا على الأطفال اللي عندهم مشاكل في التنفس. فنبتدي بحالة ممكن الحالة دي تعدي عليكم. عندنا post term infant يعني 42 weeks gestation, emergency C-section, meconium at birth, infant is tachypnic. فانت دخلته عندك في النيونيتال انتنسيف كير يونت بتاعتك، حطيت البيبي على اكسجين 80%، عملت للبيبي بلاد جاس، ال O2 42 CO2 35 pH 7.47، ودي الاكس راي بتاعته. اكس راي شكلها fluffy infiltrates hyper expanded. فده ايه الدايجنوسيس بتاعك؟ meconium aspiration syndrome عند requiring high oxygen. فالبيبي ابتدى يتعب، فانت محتاج تحطه تعمل له ايه؟ البيبي بيتعب، الاكسجين بتاعه low 80% oxygen, tachypnic, looks blue. what would you like to do? Would you like to put him on a mechanical ventilation? Okay, لو هتحطه على mechanical ventilation, what setting would you write? PIP, PEEP. What do you want? 20/4. Okay. Rate 30. I time 0.4. كلكم متفقين على الموضوع ده؟ طيب. اوكي، عندنا طفل تاني، يعني ده راح جاب البيبي ده في الوحدة، في دكتور تاني راح زميله جاب البيبي التاني 27 weeks newborn grunting, retracting. حطيته على CPAP 30%, PO2 62, CO2 86, pH 7.04. ودي الاكس راي. الاكس راي شكلها ايه؟ so severe RDS. تحب تعمل له حاجه؟ mechanical ventilation. ايه السيتنجز بتاعتك؟ 20/4. اوكي. 60. هنزود له الريت شويه. اوكي. 0.4 اي تايم. كلكم متفقين؟ يعني بيزيكلي هنعالج الاثنين نفس الحاجه بس هنزود الريت في ده عن ده. طيب حل الاثنين المكان حل اللنج ديزيز in the two babies is the same or they're different? So if they're different, why would you use the same settings? عشان نقرر احنا هنبتدي عشان نقرر نعمل ايه يعني we need to understand what is the problem with the baby's lungs, what this lungs need to get better, what this baby needs from me as a physician to apply in the ventilator to improve things. So the idea is from this talk is we have to think what is the problem with the baby's lung. So in order to do that, and you will see how we do this over the course of the 2 days, we will talk about first what are the basic things in the lungs. So these are the objectives from the talk is to recognize different types of respiratory failure, review some important principles of pulmonary physiology, understand it. Every baby has a different disease, and this applies not only to babies, applies to children, adults. You have to understand what's the problem with the lung, what is the problem with the breathing issue for that. Okay, so we recognize the respiratory failure as impairment of lung abilities to maintain adequate oxygen and carbon dioxide homeostasis. And in general terms, if the PO2 is less than 60 in room air or oxygen, or the PCO2 is more than 50, that's considered respiratory failure. We may accept CO2 more than 50. Like in premature babies, we do accept 50, 55, 60, and we call this permissive hypercapnia. But if the PCO2 is more than 50, it means that the lung's function is impaired. It's not a normal lung function. It can be acute, subacute, or chronic, and we will see how this makes a difference. And there will be compensation, so the pH will be higher, the CO2 will be retained, and the pH will be higher, and then we'll see about how we diagnose respiratory failure for that. It's a big problem, causes lots of morbidities and mortalities. Optimal ventilatory management will reduce mortality and will reduce complications from the breathing problems. And this should be individualized to be based upon the pathophysiology of every baby, and you convert this pathophysiology to strategy on the mechanical ventilation. So what are the physiologic functions of the lungs? You're sitting here, all of us are breathing. What does your lung do? Speak up. What does your lung do now? Gas exchange. Gas exchange means you take the gas from here, put it there, and from there put it here. So what are the functions that it does to achieve this gas exchange? Gas exchange is the final product. VQ matching. VQ. What is V and what's Q?
Ventilation diffusion.
Okay. So first you have ventilation. Okay. So ventilation is what? Air in, air out. So air in from outside to the alveoli, air out from the alveoli. So the first function is ventilation. Second function is, so air in, air out. We want to exchange the air, exchange the gases between outside and the blood. So this is the gas exchange. So first part is the air needs to go inside the alveoli. Then what is the second part? What needs to get into the alveoli also? Blood. So we call that perfusion. So blood goes into the lung. So now blood is in the lung, air in the alveoli. Then what needs to happen? Which is we called diffusion. Gases has to go from the alveoli to the blood and from the blood to the alveoli. So that's called diffusion. So there are three main functions of the lungs. ventilation, perfusion, diffusion. Okay, and this achieves gas exchange. So gas exchange is a product of these three functions. Now the lung does some little other things like ACE deactivation, some hormonal issues, but none of our business. So this is the anatomy, and as you can see, the lung does not work alone. It has to have airways, upper airways, and they have a very important functions, mostly humidification and air transport. You have a trachea, then it keeps dividing, and it keeps dividing into bronchi, bronchioles, and then terminal bronchioles or respiratory bronchioles where you have alveoli. We also have diaphragm, and we have rib cage, chest wall, very important. So the way it works is trachea is generation 0, and it keeps dividing till the alveolar sacs at generation 23. So this divides into 2, this divides into more, this keeps dividing and dividing and dividing. So this is in a premature baby, the division, you have some alveolar sacs or air sacs at around 24 weeks gestation. Okay, but you don't have the full alveolarization of the lungs until term. So when babies are born prematurely, what we'll talk about some of in the other lectures, that there's maturational arrest, that the normal process that is supposed to be going on inside the womb while the baby is not breathing but allow the lung to develop gets interrupted. So it's important to know the process and how much division. Now, how many tracheas do we have? 1. How many small bronchioles do we have? Thousands. Okay? So even though they're very small, there are so many of them. So this will tell us which part has more resistance, which part has more restriction of flow. The trachea, which is very big but one, or the small bronchioles, which are small but so many of them. The small bronchioles have less resistance because there's so many of them. So if you cut them and you stick them to each other, their cross-sectional area will be very wide. So this is total cross-sectional area, that the cross-section, which is when you cut it, only one round thing in the trachea. But as you go down the generations, you have lots and lots of them when you put them together. So this is called cross-sectional area. So this is ventilation part to get the air inside the alveoli. Now, this is the perfusion part. Now, the pulmonary artery brings the blood, then the capillaries surround the alveoli. It's only 2 layers of cells between the blood in the capillary and the gases in the alveoli. So 1 layer of the endothelium of the blood vessel and 1 layer of the cells in the alveoli. How many different cells do you have in your alveoli? 2, right? So type 1 cells and type 2 cells. Type 2 has to do with surfactant, type 1 has to do, the hematocytes have to do with air exchange. So this is perfusion part, and when these 2 structures, the alveoli in here and the blood vessel in here, it allows the diffusion of gases. So this is how the lung functions normally. Now, the air, the gases in the alveoli, can you see it? Because I don't see my cursor. Okay. The gases in the alveoli are within, this is the alveolus here, and this is the capillary. The gases are in very well equilibrium. By the time it leaves the alveoli, the gases inside the blood and inside the alveoli are the same concentration, same partial pressure of gases, PO2 and PCO2. So ventilation depends on conducting airways on open alveoli. So it moves air in and out. So we need to know what volumes of air is in. So you all remember this from medical school. This is tidal volume. This is the air you breathe out when after you breathe in and normal breath. So all of us sitting here now, we're breathing our tidal volume. Then if we take a very deep breath, this is called inspiratory reserve volume. If we exhale very hard, this is expiratory reserve volume. After you exhale very hard, you still have some air in the lungs. The lungs does not collapse completely. Okay? And we all have, excuse me, negative and pleural pressure. Okay? We'll talk about why is it negative. Why do you have a negative pleural pressure? How does that happen when we get to the compliance portion? But the lung does not collapse completely. It has residual volume. Very important is the functional residual capacity. You'll hear a lot about this. So the functional residual capacity is the air that is present in the lung after you exhale normally. And this makes it easy for us to breathe because the lungs is already open and it stays open. So compliance is how easy it is to expand the lung. If it's very hard for me to expand the lung and I have to work hard, what would you call that? Is it good compliance or poor compliance? Poor compliance. So poor compliance makes it hard for the lungs to open up to stretch. So it is dependent on distensibility of the lung tissue and the surface tension inside of the alveoli. We call it change in volume over change in pressure. So there is dynamic and static at a certain point of time. What is the compliance? Is volume over pressure, or the dynamic change in volume over change in pressure. Normally it's about 3 ml per centimeter of water. If it's a baby with surfactant deficiency, it will be much less than that. So they have poor compliance. Now this is very famous loop or curve of pressure volume. This is pressure. Do you see my cursor? Okay, here it is. This is pressure and this is volume. So who here has, anybody has children who likes to play with balloons? Yes? Okay. Did your child ever give you a balloon to inflate for him or her? Say, Mommy, please make this big for me. So what do? Put it in your mouth and you blow in it, right? Then what happens? Nothing, right? So then you blow a little harder. Then what happens? Still it does not want to inflate. Now your child is losing trust in you and he's starting to look around for someone else, so you're going to look bad now. So what do? Blow real hard, right? So then what happens? All of a sudden the balloon gets a little bit bigger. Now your child wants it bigger. So what do? Blow in some more. Now is it as hard as the beginning or is it easier now? It becomes easier. Okay, now if you keep blowing it and blowing it, what will happen? It will reach to a point where it cannot expand anymore. Then it will blow. Then you have to do this over again with another balloon. So this is the opening pressure, what we call opening pressure. As you can see, from here to here, the pressure increases, but there's no volume. It didn't increase until you reach the point that you open the balloon. Then the volume increases. Then it becomes easier for the volume to increase as you blow, you generate more pressure. Until you reach your limit where it's no more expandable and it would rupture. It will probably not rupture in the first breath, but it would rupture if you keep going because it cannot expand anymore. Now the very interesting thing about this curve is, we'll talk about oxygen dissociation curve later in the blood gas talk, but all curves like bell curve, oxygen dissociation curve, they go one way, they come back the second way, the same way. They don't change. This one is different. And this is very characteristics of lung tissue. It goes up one way and it comes down in a different way. We call this hysteresis, is that the difference between the way it goes up and it goes down. And we see how this is important in how we deal with these lungs when we do mechanical ventilation. Okay? Now, if we let all the air comes out and the volume comes to zero, then when you take the next breath, what do you have to do? You have to start from the beginning. So you have to generate all the energy, to generate all the pressure to get the lung open. While if you let some air in, then you can start from this point. You don't have to start from zero. It's easier to keep the balloon inflated. It's less work for you. So it's very important that the lung has some volume left in it rather than completely collapse. And in babies with respiratory distress syndrome who has no surfactant, this is what happens. The lung, if you don't do anything, if you leave the baby alone, then it's hard to open the lung, not much volume. This is pressure, this is volume. So you get, with a lot of pressure, you get a little bit of volume. Then when you let the air out, then all the volume goes down. So next breath, what does the baby have to do? Start over again. So how do you see this on the baby? Retracting. Baby's retracting, doing a lot of effort. Okay, what else do they do? They grunt. What is grunting? Okay, what they do is, rather than, they try to keep some air in till the very last moment that they have to take a breath. So instead of letting all the air out, they close their glottis. So they take a breath and then they take the second one. So in hope that if they keep their lung open, it will be easier for them to breathe the next breath. So they're basically trying to give themselves PEEP by holding their glottis closed and keeping the air inside the lungs. Versus a normal baby who will take a breath, the volume goes up nicely and it does not come down to zero because now you build up your residual volume and your functional residual capacity. Also, we'll talk about this a little bit more in the next talk about, or the workshop about, how do you deal with this pressure volume curve when it changes? What does that mean? So we'll talk about it later, but we can also represent the relationship between pressure and volume with one line. As the pressure goes up, the volume goes up until you reach a limit where the volume does not go up anymore because you've reached the limits of expandability. And now I want to choose my settings. Okay, so I pick PIP and PEEP. So 20/4. Why not 22? Why not 25? Why PEEP of 4? Why not PEEP of 6? Why not PEEP of 3? So we need to decide. How do you decide that? Okay, let us look. For example, if I choose my PEEP here, like low PEEP, and this is my PIP. Okay, now the baby will be breathing in this area. So this is pressure and this is volume. Or I can choose my PIP here and my PEEP here. So now the baby will be breathing in this area. Or I can choose even higher PEEP and higher PIP, and the baby will be breathing here. Which area is best for breathing for the baby? Up here, low here, or in the middle here? We're talking about if you change pressure, how much volume you get. If you want to do pressure, you want to work. Do you want to get small volume or large volume? When you're breathing, what do you want to do? You want to get small volumes or large volumes? Large volumes, right? Because small volumes means you want to work harder. So which areas on this curve will give you the most volume for your pressure change? It is the middle one, right? Because the middle one, this is volume, this side. So you get a lot of change in volume for small change in pressure. So you're buying good. You're spending small amount of energy to generate small amounts of pressure, but you're getting good volume for it. So every baby may have a different pressure volume curve. And even the same baby, if you give him surfactant, for example, you will change his compliance. You will change his pressure volume curve. So before and after surfactant are different. So we need to think where is this baby from clinical exam, x-ray, and we'll see how we can tell a little bit about that from graphics, or tell everything from graphics, but with the limitation of what graphics we use, of how you can tell which is pest PEEP and which is pest PIP. But the idea is some people just increase the PEEP until, in adults, what they do is they keep increasing the PEEP until you get good oxygenation, which means you've opened up the lungs. The goal for now is not to give the least amount of pressure possible. The goal is to give the proper amount of pressure. The amount of pressure that keeps the lungs open without causing damage. Not too much, not too little. Because not too little is not good either. Then too little, then the baby's working here. Okay, which is hard work. So sometimes we need, especially babies with chronic lung disease, they will need higher PEEP because some of their lungs areas are collapsed, some are open. So we need to open everything, because if you leave the collapsed lung collapsed, then you're losing good parts of the lungs, and that you will need to change to generate a lot of pressure in a collapsed lungs to get some air exchange in. So it's very important to understand that we want to get the lung open, fully open. Then you can ventilate this lungs much easier than if the lung is collapsed. Now, the idea is as we increase the pressure, as we've seen, you improve your oxygenation until you hit a level where you're in the good zone, in the middle zone. If you increase it more, then your oxygenation will start decreasing because you're over distending the lung, you're squeezing the blood vessel. So this is the relationship of mean airway pressure to PaO2. As you increase your mean airway pressure, and you can increase your mean airway pressure in many different ways, so it's not universal, but in general, as you increase your mean airway pressure, you'll improve your oxygenation till you hit a limit, sweet area. Then if you increase it more, you'll cause more trouble. And we'll see how that works in later on. So high mean airway pressure can cause hyperinflation and can cause decreased cardiac output. So you want the mid zone where everything is okay. Okay, we'll take a little time. Let us move on little in the compliance part. Why is surfactant so important? Like, why babies with surfactant deficiency have a problem? Okay, so surface tension is very important, okay? And this is the famous Laplace law. You don't have to remember, but the idea is the pressure inside here is inversely proportional to the radius, and it's twice, and it's proportional to the surface tension. So if you have alveolus with no surfactant, so there's no surfactant, this is baby with RDS, 26 weeks, has no surfactant in his lungs, or very little. Now, one of the alveoli is big, and one of the alveolus next to it is very small. So, which alveolus will have higher pressure? The one that is big or the one that is small? Both of them are lacking in surface tension. Both of them have the same low surface tension. It's a very bad lungs, no surfactant. So, because the pressure is inversely related to the radius, this one has a bigger radius. So this one will have high pressure or lower pressure? Lower pressure, because it's inversely related. As the radius goes big, the pressure goes down. As the radius becomes smaller, the pressure goes up. Okay? So the one with the bigger radius will actually have less pressure. It's like the well-inflated balloon and the very small inflated balloon that's not well inflated. The bigger balloon is actually having less pressure. So it ends up that the small alveoli will empty the air, because the pressure here is higher, will empty the air here. So one of the alveoli will get over-distended and one will collapse. So what does surfactant do? When surfactant lines the alveoli, if an alveolus becomes small, the surfactant molecules gets tight together. So it lowers the surface tension a lot. And if the alveoli is getting bigger, the surfactant molecules disperse from each other. They become far away. So the surface tension goes up a little bit. So this actually creates equilibrium. It stabilizes this alveolus because now the surface tension has dropped. So the pressure has dropped. So now the small alveoli, when it becomes a little smaller, the surfactant molecules get together and they lower the surface tension. So they avoid this alveolus from becoming collapsed. So this is the importance of surfactants. So now many studies where they're trying to do, so if you have a baby with RDS, give him surfactant and extubate rather than let him be on a breathing machine or CPAP for a long time with some alveoli collapsed, some open. So this helps. The surfactant function is very important in stabilizing the alveoli and avoiding over distension. Now the other part is we have airways. So resistance of the airways, it resists the flow of air, is an important part of how much flow we order, how much is our I time, because this will affect how much flow and resistance we get. So the resistance is change in pressure over change in flow. It differs, obviously, if you have a big cross-sectional area, a big tube, there is less resistance than a small tube. So if the baby is breathing by himself or breathing through an ET tube, which one has more resistance? ET tube or normal breathing, no ET tube? ET tube, because the ET tube has more resistance because it makes the diameter even smaller. So the cross-sectional area, because you have to put the ET tube inside the trachea. While if the baby is breathing spontaneously, has less resistance. The length of the airway, the longer is the tube, the more resistance. So if the baby is intubated, is it good to have an ET tube this long or in just an ET tube that's a little above the mouth? Short ET tube, longer one will increase more the resistance. Flow rate, okay? If you have very fast flow, it will create turbulence because it has a fast flow will have more friction with the wall of the tube. So proper amount of flow is very important. And the last thing is density and the viscosity of the gas. It's like if you're pushing honey versus pushing water into a small tube. Which one will have more resistance? Sticky stuff will have more resistance. So when do you use this? We don't use it much in neonatology, but pediatric intensive care, they do that. Like if you have an asthmatic, for example, what do asthmatics problems? Airways, right? It's not a problem with the compliance. It's a problem with the resistance of the airway. So if you want to decrease this resistance, what do? You add some gas that has low viscosity, like helium. Okay, so now people can use helium added to air because this has less viscosity and allows less resistance to the flow of gases to achieve better ventilation. So all these principles are used, and we use it on a daily basis. The one thing I want to mention before we go on is that resistance is inversely proportionate to the radius to the fourth power. So radius times radius times radius times radius, which means any small change in radius will make a big change in resistance. And this is more so in babies, little babies. This is a cross-section of their trachea. If you have a little bit of edema, like if you have 4 millimeter, and if you have an edema of 1 millimeter, so this takes 1 millimeter from this side and 1 millimeter from this side. So the 4 millimeter became 2 millimeter. Okay, so you dropped the radius by half. So because it's 2 times to the power of 4, so 2 times 2 times 2 times 2, you've actually dropped it by 16 times. You increased the resistance 16 times. Imagine if you also have some secretion in the ET tube. So now the ET tube that is 2.5 millimeter diameter becomes 1.25. Same thing, you increase the resistance dramatically. So it's very important to make sure that you clear the ET tube. In adults, when they have big airways, it's not as significant as it is for little babies. Okay, we've mentioned about the resistance and airway generation. The more generation, the actually less resistance. So most of the resistance of the airways for preterm babies is in the upper airway, your ET tube. Okay, this is where you get the most of the resistance. Time constant is an important concept because that's the basis for your I time. This is how you decide your I time. The time constant is the value where it's compliance times resistance, but the idea 3 to 5 time constant is the time it takes for the lung to fill up or empty. So in one time constant, which is easier to fill? A small balloon that only goes from here to here, which will take less time, goes only from here to here, or a big balloon that will go from here to here, which will take less time, less attempts to blow it. I only have from here to here. This is all it's going to go. Or I have from here all the way to here, which will take me more time to fill. The big ones, because I have to get it from here to here to here to here. Whereas the small ones, I only have to get it from here to here because it's not going to go anymore. So actually, the more compliance, the longer is my time constant, and the longer it will take me to fill, and the longer it will take me to empty. So as the baby's compliance gets better, you actually need more I time. So for example, in this little premature baby, the 27 weeks with bad RDS, he actually needs a short I time. A very long I time will show you how it looks in the graphs, will not allow for good gas exchange. This kid, you need an I time of 0.3, 0.3 something, but 0.4 is definitely way too long. And we'll show you what it looks like, because what happens is, if you put it 0.4 I time, it will fill up, the lungs will fill up in 0.2 seconds, or even less. Then for the next 0.2 seconds, nothing will happen, no air exchange, because no more air can get in, it's filled. So this is we call respiratory pause or respiratory hold. Sometimes we like a little bit of a respiratory hold because we don't want the alveoli to collapse. That helps recruitment. But we don't want very long respiratory hold. So when you have poor compliance, you want short I time. When you have good compliance, you want long I time. And that's based on the time constant, because you need 3 to 5 time constant to get the lung fully inflated or fully emptied. And this is kind of the calculation. This is very important, the perfusion ventilation matching. Now, normally, the lungs that, this is the alveolus, and this is the capillary that gets the blood into the alveolus. So if the alveolus is nicely open and inflated, then the blood will come here, exchange gases, and becomes pink on the other side. Okay? This is all we want to do that. Then we're happy. We have good ventilation, perfusion matching. Areas that are ventilated are well perfused. What if there is a excretion or a plug? No ventilation. Or this is full of exudate, bad pneumonia. Then what happens? The gas that comes, the blood that comes from here, will it exchange any gas? Will it pick up any oxygen? Yes? No? Maybe? No, it will not pick up any oxygen. It will not be able to get rid of the CO2 because nothing is going on. Okay, so this is ventilation is 0. So now the blood comes from here, goes to the other side the same way. We call that shunting. Okay, so you're shunting the blood just from there to the other side without getting anything, without achieving any gas exchange. Okay, on the opposite end, this is very severe. On the opposite end, here you have ventilation, but there is a blood clot or extreme vasoconstriction. So the air goes in and out, but there's no flow. So there's ventilation, but no perfusion. So these are the two extremes that can happen to the ventilation perfusion matching. Normally, we're somewhere in between. We're not, all babies are not either completely perfused or not perfused at all or in the middle. So we have a range. And most of our problems, most of the ventilation or the breathing problems for babies is related to ventilation perfusion matching. Now, do you want this area to ventilate, to perfuse? Like here you have plug in the airway, so this alveoli is not getting air. So do you want the blood to come here to go to the other side? Or you don't want the blood to go there? Yes? No? Maybe? You want the blood to go to this alveolus? Yes? No? No, you don't want the blood to go there because it's not going to help. So what usually happens if you have pneumonia and there is consolidation, this alveolus is full of secretion or has a plug here. So what do you want to happen here to this vessel? You want it to vasoconstrict, right? So the blood can go to areas where you can have some gas exchange. So we call that what? No, we call that the blood vessel vasoconstrict. When there is hypoxemia in this area, in this alveolus, we call that hypoxic pulmonary vasoconstriction. Okay? The fetus in the womb, do they have high pulmonary pressure or low pulmonary pressure? They have high pulmonary pressure because the lungs, there is no oxygen in their lungs. So their lungs vasoconstricts. So the blood shunts from the right side to the left side. Okay? So physiologically, this is good. When they're born and they still have the same pulmonary vasoconstriction, then now we need to do something about it. We need to improve the conditions because without any of the still severely vasoconstricted, then they will not get any oxygen. Okay? So this is extreme for zero ventilation with a perfusion. So 0 over anything is 0. So VQ is 0. Here there is ventilation. This is again extreme at this point. So something, ventilation is whatever, over perfusion which is 0, that's infinity. So we want to be somewhere in here, correct? Where you have good ventilation, good perfusion. Now our lungs are not all similarly distributed perfusion ventilation. Some parts of the lungs, because I'm standing up. So the top parts of the lung is actually sitting on the bottom parts of my lung. So more blood, the top part is lighter. So gas will find it easier to go to the top part than it is to go to the lower part. While blood that's getting pushed goes down to the lower part more than the upper part. So all of us sitting here, I think, have some VQ mismatch. Our VQ is not perfect. Okay? So babies who are sleeping on their back or laying on their back, which parts of the lung gets more ventilation? Top part, right? Okay, which parts of the lung gets more perfusion? The back part, the lower part. So there is some ventilation perfusion mismatching. Am I going over time? Please let me know. Okay. So normally there is a little bit of ventilation perfusion mismatch, and generally it does not affect us. We still function properly, but sometimes it's actually good because the lower part, the back part of our lungs is bigger than the front part because the diaphragm curves. So prone ventilation is like if you have a really sick baby and it's hard to ventilate him, actually prone may help because when you ventilate, if they put the baby prone, then you'll ventilate the back part of the lung, which is bigger than the front part of the lung. So you can use that as some way to help with getting a little bit better ventilation. But as I mentioned here, most of our problems are related to VQ matching, either some areas that are collapsed, that are not getting well perfused, or some areas that are not getting good enough blood flow to it, like pulmonary vasoconstriction from sepsis, from thrombexan A2, from products, from abnormal vasculature of the lungs. That gives us most of our problems. We'll skip this part. This part we'll do with the blood gas. So the idea is we need to understand how the lung works, what is compliance, what is resistance, what is VQ matching, and apply that to the baby's problems, the baby's condition. So if ventilation, for example, air in and air out, can be sedated, can have CNS problems, may not be able to initiate the breathing, muscle problems, chest wall problems. Perfusion can have shunting if you don't have the proper perfusion to the ventilated areas. VQ mismatch if you're not either perfusing non-ventilated area or having some vasoconstriction, so you're not perfusing the ventilated areas. And diffusion, this is extremely rare in newborns. Okay, all our problems are related to either ventilation, perfusion, or VQ matching. Newborn babies don't have much related to diffusion, some lymphangiectasia, other issues that are not common at all. Okay, so causes: hypoventilation, CNS muscle airway, right to left shunt if you have decreased cross-section, abnormal vessels like diaphragmatic hernia, for example, hypoplasia, VQ mismatch in cases of atelectasis, pneumonia, interstitial fluid, pulmonary edema. All this will cause VQ matching. And as you can see from the list, most of our problems will be with the VQ matching. Okay? Usually CO2 diffuses much better than oxygen. So if you have high oxygen, or if you can have low oxygen alone, but if you have high CO2, usually you will need more oxygen. And when we talk about the alveolar gas equation, we'll see why when your CO2 goes up, your O2 will go down. So usually if you have CO2 retention, you will need more oxygen, but not necessarily the other way around. Okay. Just a reminder, minute ventilation is tidal volume times frequency. And minute carbon dioxide elimination is mostly related to minute ventilation, while oxygen is mostly related to mean airway pressure, but within limits. As we've mentioned, if you increase your mean airway pressure, you can cause more problems. You reach a good zone, then too much, too little, not good. We just mentioned this because this is very important now that we use hybrid modes. We use volume targeted ventilation. So all mammalians are lung volumes or tidal volumes is 4 to 8 ml per kg. For premature babies, we tend to stay 4 to 6 because we think that the volume causes more damage to the lungs rather than pressure alone. So we need to take whatever pressure we need to attain proper ventilation. If we use smaller tidal volume, it's not good because this will not allow ventilation. It will cause atelectasis, and that will not help the lungs. Okay, so now back to our case. 27 weeks gestation, grunting, retracting, 30% oxygen, PO2 62, PCO2 86, pH 7.04. You saw the X-ray already. So what's your diagnosis? RDS, okay. Is respiration is okay, or you want something? This is respiratory failure. His PCO2 is 86. This means the lung is not able to function to keep the CO2 less than 50 as it normally would. So this is respiratory failure. We used to call them type 1 and type 2. Type 1 oxygen, type 2 CO2 plus minus oxygen. So, but it doesn't make any difference as long as you realize this kid needs help. Okay? So this is CO2 retention, and this baby is in respiratory failure. So what do you do? What is the problem? What is the pathophysiology behind this? You already have. What is this? Sorry? So raise your voice. Somebody from the back. What is the X-ray shows you? Good inflated lung, badly inflated lungs? Poorly inflated lungs. Small lung volumes, white out. Which means, why is it white? Because there is no air in the alveoli. Air is black. So if the alveoli is collapsed, it will be white. Okay? And sometimes if you get picky, you can see maybe an air bronchogram. Why do you get an air bronchogram? Speak up. Okay. So the collapsed alveoli gives you a wide background where you can see air lines in the bronchioles. It's okay, normal to see that in the heart, because the heart silhouette is white. So, but normally the heart silhouette is white, that's fine. So this does not count as air bronchogram, but this does. Here, this is air in the bronchi under a wide background from collapsed alveoli. So what's the pathophysiology here? Is it hypoventilation? Is it VQ mismatch? Is it diffusion problem? It's VQ mismatch because there is no ventilation. Ventilation is impaired. Okay, because why is the ventilation impaired? Because of collapsed alveoli. So you don't, the blood that goes from the heart to the lung does not really go to the alveoli to pick up oxygen and to remove CO2. So this is VQ mismatch because ventilation is impaired because of the collapsed alveoli. Okay? So what would be my treatment? Your treatment? Improve ventilation. So open up the alveoli. You can give them surfactant, you can give them more PEEP. So I wouldn't do PEEP 4 on this kid, for example. Okay? I'd probably do PEEP 6. Because his alveoli is so collapsed, I would like to open them up. Okay? So now I'm looking at this and I'm adjusting my ventilator settings. Okay, so it's acute respiratory acidosis. We'll talk about it later. Hypoxemia, hypercarpia, and we said reduced lung volume, VQ mismatch. Okay, now the second baby, post-term, meconium, tachypnic, 80% oxygen, PO2 42, CO2 35. What does he have? Okay, what is pathophysiology? And what is he in respiratory failure or is he okay? Can you leave him and go home and then call on the phone and find out what's going on with the baby? Why respiratory failure? CO2 is 35. Okay, so low O2. So low O2 less than 60, even though you're giving him oxygen, so that's respiratory failure. What is his mechanism? What is the pathophysiology? What happens in his lungs? Okay, so he has part of the alveoli that has pneumonia, has exudate in them from whatever irritation, infection, meconium. Okay, so these alveoli would ventilate. Okay. Okay. Now, so how about the other alveoli? Are they ventilating? Okay. What do you think about his lung volume? Where is his lungs? Where does his lung end? See? All this is lung. This is lung tissue. You can see the reticularity here. This is lung tissue in front of the diaphragm. So what do you think about lung volume? Remember the first baby had small lung volume? This is lung volume small or large or okay? This is high lung volume. Okay? Why is it the lung volume is high? Because he has some air trapping, because meconium can normally, your airways constrict a little bit during expiration. So air would go in, and during expiration, not all the air will come out. So you get air trapping. So some of your alveoli are collapsed because of the pneumonitis, because of this exudate in them. And some of your alveoli are over-distended. So if they're over-distended, they don't get perfused very well, because the blood vessel is constricted. You have a blood vessel and you have alveoli. If the alveoli becomes stretched, it squeezes the blood vessel. Okay? So what do they get? You get shunting. Okay? So this is VQ mismatch with shunting, because you decrease less perfusion. Some alveoli are not well perfused because are perfused but they collapse, no good ventilation, and some alveoli are not well perfused because the alveolus gets over-distended, squeezes the blood vessels and causes shunting. This is intrapulmonary shunting. The blood would go to the other side without passing by the normal alveoli or the open alveoli. Okay, so this is also VQ mismatch, and it's on the severe side, so we call it shunting. Okay? So this is hypoxemic respiratory failure, over-distension and air trapping, and VQ mismatch and shunting. Okay, you want one more case or we're done? Taib? Up? Okay. One more case? Okay, one more case. Children, you see children? Okay, we'll do one child. 5-year-old, bronchial asthma, 2-day history of running nose, cough, poor appetite, required oxygen for cyanosis, admitted to pediatric ICU, 60% oxygen, nasal cannula, breathing 60. pH 727, CO2 41, PO2 35. What does he have? This is his film. He's asthmatic, and now he is having upper respiratory tract infection, viral something. So what does he have? Normal lung function or problem? Respiratory failure. His PO2 is 35. Okay, so, and now what do you do for him? Give him some bronchodilators and hope that he has hypoxemia and he had acute respiratory failure. So what's his pathophysiology? He has hyperinflated lungs. So with hyperinflated lungs, as we've mentioned, the alveoli are way too open. It can compress the blood vessels, increase pulmonary vascular resistance, and it can cause shunting. So it's severe VQ mismatch. Okay? So hypoxia is inadequate oxygen delivery. So ventilation is okay. 12 hours later, he's more distressed, intubated, ABG on 100% oxygen, CO2 55, PO2 59. Now what's your diagnosis? Is he still in respiratory failure? Yes, he's actually worsened because he's in 100% oxygen, his PO2 is only 59, which is still respiratory failure, less than 60 in room air, and his CO2 went up. So he's actually worse. So, and what's your diagnosis now? Now he has atelectasis, intubated, he has a little pneumatocoel. Okay, so now, what's your pathophysiology now?
Asthmatic from heart.
Okay, so he's asthmatic, and it's still VQ mismatch because some areas of the alveoli are now collapsed with this pneumonia. Some areas are over-distended. So it squeezes the blood vessels. It does not allow proper perfusion. Okay? So this is how we approach the problems by understanding what is compliance, what is resistance, what is VQ mismatch, what is VQ matching, and then decide our settings. So probably for a baby, for a child like this, I may need to have, if the problem is in the small airway, then I will give him some bronchodilators. Probably I wouldn't fit a very high PEEP on this baby because he's already having air trapping and overexpanded. I may use a low eye time and short eye time and faster rates for a overtrapping. Now, when we talk about the modes of ventilation, we have to know when we trigger, because now you're using patient-triggered ventilation, correct? So you need to know how much the sensitivity, the trigger sensitivity. If there's water, would it trigger more? If the child is tachypnic, is this good or not? Do you want him to run the vent at very high rate or not? Because he can make the vent go fast. So we'll need to know, because you want your IE ratio to allow for good enough time for expiration. You don't want a short or inverse IE ratio or equal IE ratio. You want the expiration to be much longer than inspiration to allow for the air trapping to improve. Okay? So in summary, mechanical ventilation, you have to understand physiology and pathophysiology, and you have to individualize your plan according to each patient's problems to minimize lung injury and optimize outcome. Thank you very much for your invitation. And I would like to invite you, this is our neonatal ventilation conference. We hold it on October 18 and 19 in Dubai. So you're all welcome to join us. Thank you.